Kia ora koutou and good evening, everyone. Welcome to tonight's Goodfellow unit webinar titled Unlocking Options, Insulin Use in Type 2 Diabetes Management. My name is Anthony Dewan, and I'm a fellow GP in Tamaki Makaurau, Auckland, and tonight we'll be joined by Dr. Ryan Paul. Ryan is an endocrinologist at Te Whatu Ora Waikato and is an associate professor of medicine at the University of Waikato. He is also an honorary senior lecturer at the University of Auckland and a clinical associate of the Maurice Wilkins Centre. Tonight's webinar is sponsored by an educational grant by Novo Nordisk, and the content was developed independently by the Goodfellow unit and our expert speaker. I'll now hand over to Dr. Ryan Paul.
Kia ora Anthony and kia ora tātou. And said the si ko Ryan Paul tapunga and ka ngata maru te iwi no kira kira roa aho. Thank you for joining us. Please feel free to ask any questions that you want in the Q&A function and we'll come through at the end. This is your webinar and keen for you to get the most out of it that we can. So we'll kick off, and really that probably the last 5 to 6 years has seen the most change in diabetes care in Aotearoa, probably from the previous few decades before that. First of all, we had vildagliptin arrive in 2018, empagliflozin, our GLP-1 receptor agonists from 2021. And it has changed the face of diabetes care. It has moved insulin down the pecking order in terms of our ladder to treat glucose levels. And the reason why, I know this webinar will focus on insulin, but it's really just making sure we know why others typically preferred in most people before insulin. We know that metformin, empagliflozin, GLP-1 receptor agonists, for that, dulaglutide or Trulicity, or liraglutide or Victoza. We've now got Wegovy and semaglutide in that boat as well as pioglitazone, all reduce cardiovascular disease independently of glucose levels. And we know that 2/3 of our whānau with diabetes will die from cardiovascular disease. So that's what we want to prevent. So they're all important. Metformin and empagliflozin or Jardiance, or Jardiance if in combination with metformin, and GLP-1 receptor agonists all typically lead to weight loss, which most of our people with diabetes would benefit from. Others, vildagliptin carbos are weight neutral, but we know that part of the issue with insulin therapy is the potential for weight gain and also hypoglycemia. Because one take-home message would be that hypoglycemia or significant hypoglycemia only ever occur on insulin and sulfonylureas. You can use all the other medications together, and it's absolutely safe and effective without the risk of hypoglycemia. As soon as insulin and sulfonylureas come on board, you've got that potential risk, but there's ways of minimizing that risk as well as weight gain, which we'll go through in detail tonight. But the reason why insulin is still important, despite all those other tools in the armory, we know at least 1 in 6 people with type 2 diabetes will still need insulin therapy to reach their targets, particularly young people with diabetes, a tamariki and rangatahi with type 2 diabetes. It's a completely different disease. They do need insulin early, and they're a special group as well that we need to really target and prioritize care for. But there are a lot of changes happening in insulin therapy in terms of availability, and that's part of the trigger for tonight's webinar to keep you up to date. And just a very brief summary of the major changes. So Pemmix 30 was one of our major sort of pre-mixed insulins we used to use. That's now gone. We now have Ryzodeg, which is 30% aspart or 30% Novorapid and 70% Degludec, which is actually our first ultra-long-acting insulin in Aotearoa, and we'll talk about that. So it's even longer-acting than Lantus. So that's been available now for a few months. And next year, we're going to see some big changes. So Novamix 30, which is another major pre-mixed insulin that will likely go around about Easter time, and Protophane and Atrapid, which have been the key insulins for many, many decades. They will likely go by the end of the year. Or still the 10 ml syringes available, also 10 ml vials to be used with syringes, but the 3 ml cartridges and pens for both Protophane and Atrapid will go. So there are lots of changes on the horizon coming up. So what insulins we will have available, and these are just the main types. So our basal insulin, also known as our long-acting or intermediate-acting. We'll still have glargine or Lantus, so that will still be available. And for our isophane insulin, so we used to have both protophane and human N. Human N will still be available, and that's more sort of intermediate than long-acting. And to be honest, there's no real significant difference in terms of safety and efficacy between Lantus and isophane insulin in type 2 diabetes. Um, Basically, the main benefit of the superiority of Lantus is that only about one mild hypoglycemic event every 6 months. There's no difference in significant hypoglycemia or HbA1c. In fact, there are many situations we may choose isophane first, particularly for people that got significant fasting hypoglycemia. Our high glucose levels as a result of steroids and pregnancy as well. So there are still times where you may choose isophane first. We will have our bolus insulin or a rapid-acting insulin, so we'll still got the three. And there's Aspart or Novorapid, Vispro, Humalog, or Glutathione, Apidra. To be honest, it's very much of a muchness which rapid-acting insulin you choose, but we'll go through the different PEMs and things which may influence your decision on that. And we'll still have our biphasic insulins. So when I talk about biphasic, this is just a combination of both basal and bolus and insulin together. We'll have our premixes available, and that's going to be our Humalog Mix 25 and our Humalog Mix 50. So whenever we refer to those, the first number, number just refers to the percent of rapid-acting insulin on board. So Humalog Mix 25, for example, is 25% Humalog, so rapid-acting, 75% human N or isophane, or the intermediate-acting. But Ryzodeg fits in this group as well. Ryzodeg's a little bit different. It's a co-formulated insulin, so it doesn't need mixing or inverting before injection. You always get the right amount, and I'll talk a wee bit more about that difference as we go along. So you're probably very familiar with the terminology we use around insulin regimens, but if you're not, basal bolus is our main intensive insulin regimen that we use. In the blue here, we can see that's the long-acting basal insulin on board. In the yellow is basically the bolus insulin we're eating. If we start off with just the main meal a day, it's known as basal plus, and you work your way up to basal bolus with the main meals. Here is what our mixes look like, our biphasic insulins. So you can see just with the Humalog mix, we've got that short-acting on board, and then that tail sort of gone roughly after 16 to 18 hours. For Novamix 30, that will be going, remember, around about Easter. Has got slightly longer tail, but very similar, I guess, Humalog Mix 25, just in that breakdown. But Ryzodeg 30 is the new, I guess, cab off the rank. And what that does, it's got both that 30% rapid-acting component, but the Degludec, as you can see here, is our truly first ultra-long-acting and does provide much more of a 24-hour cover. So it does become more attractive as a one injection a day option, which I'll also talk about, which insulins do we choose. So in terms of when do we need to start insulin, I spoke about 1 in 6 people still needing insulin for those with type 2 diabetes. And this is, even though our focus tonight is on insulin, this is another, I guess, important take-home message, is that we know people with type 2 diabetes have typically lost about 50% of their beta cell function, so those cells that produce insulin in the body, at diagnosis. What this means is that they will typically lose the remaining beta cell function generally over the next sort of 10 to 15 years, often a lot shorter in younger people, and then potentially a lot of people never require insulin. But what that means is it's really, really important to intervene early in type 2 diabetes, ideally aiming for remission if we can. Definitely trying to improve beta cell function, ideally so people do not ever need insulin. I'm happy to take any questions about that, as it's not the focus of tonight, but it's just really to highlight, through no fault of anyone, beta cells die. We still don't know the exact mechanism. I'm sure someone will get a Nobel Prize once it is found. But people with type 2 diabetes is typically a progressive disease through no fault of their own, as beta cell function drops off and the beta cells die. And that's why we need insulin. In fact, there are far more people in Aotearoa with type 2 diabetes on insulin than there are type 1 diabetes, just to put it in perspective. So in terms of, how does that sort of manifest itself when we realize that people need to start insulin? I think if you've ever got anyone that's got clinically insulin deficient, and those typical symptoms, polyuria, so peeing all the time, polydipsia, drinking all the time, losing weight unintentionally, nocturnal cramps, they're really key signs. And particularly if we're suspicious there may be type 1 diabetes or pancreatogenic diabetes, that's just loss of pancreatic function that can be measured biochemically. And a sign of severe insulin deficiency is if we have a C-peptide that's less than 200 at the time when the glucose is high. So please, if you're ever going to perform a C-peptide because you're worried about type 1 diabetes or pancreatogenic diabetes or insulin deficiency, please make sure you do it with a glucose. And ideally, after eating, the glucose is going to be higher rather than fasting, and less than 200 is a sign basically of significant insulin deficiency. There are also times, for example, if the HbA1c is above target despite maximal other therapy, that is a time that we typically need to introduce insulin as well. At the moment, in terms of pregnancy and breastfeeding, and insulin and metformin are only safe non-glucose lowering therapies. There are other special times, such as end-stage renal disease, end-of-life care, where insulin may actually be the and steroid-induced hypoglycemia first-line treatment. The other time when we just consider it is if HbA1c is above 90 millimole per mole any time. And the reason why we consider at that point is that basically, if you use all the other glucose lowering therapies, you still aren't often to target. Remember, our target HbA1c for most people is less than 53 millimole per mole. Saying that in terms of it's not an absolute rule. There are obviously some people who will literally drink 5 liters of soft drink or fruit juice a day. Those healthy eating measures can often get the HbA1c to target. But if there's not much room to shift there, do think about introducing insulin early. That does make a big difference in terms of keeping their beta cell function alive as long as possible. So there are many ways to skin a cat in diabetes, but there's always, if you ever get stuck, going to weight-based dosing for starting insulin will typically always get you in the right ballpark in terms of both safety and efficacy, because you don't want to start with hypoglycemia. This other side of the coin is it's nice not to take weeks or months to get glucose levels under control. So it's about weight. I'll be honest, myself and most of my colleagues will go to weight-based rather than 10 units or 5 units per se. And a good starting point for most people is 0.2 units per kilogram per day of basal insulin. So it'll be Lantus or Humulin N. And we typically give that at night because the main role of basal insulin is to do the basal job of insulin, which is to stop the liver pumping out a whole lot of glucose, particularly overnight, and other processes such as protein synthesis and reducing ketone production. Now, if you were worried about hypoglycemia, though, and if you think that many of our patients weigh 100 to 150 kilograms, and yet potentially worried, or even probably those are greater at risk, elderly people, particularly if they're frail, they may have low body weight. There's nothing wrong with starting at 0.1 unit per kilogram per day and then building up. But for most people, they will need probably 0.2 units per kilogram per day would be a decent starting point. Now, when we're titrating insulin, the best way to do that is with glucose levels. Unfortunately, there's no real other way to do it safely. With that, for those that don't have access to continuous glucose monitoring, and we'll talk about that as being an important adjunct to insulin therapy. But we're starting with having basal insulin at night. We're checking out fasting glucose levels in the morning. And basically, if we have 3 checks in a row that are above 7, we can increase the dose of basal insulin by 10% or 2 units, if that's easier. And we keep increasing that every 3 consecutive times till we ever get a glucose level less than 7 or if an episode of hypoglycemia occurs at any stage, or if doses reach zero point 0.5 units per kilogram per day. So, just out of ease. So, if someone did weigh 100 kilograms, you're stopping the Lantus or the Humula N once the dose gets to 50 units, if not earlier. And the reason why we stop at that point is because doses of basal insulin above that typically just lead to weight gain, which most of our people don't need, and they don't really lower glucose levels. So one thing which I'll talk about quite a bit tonight is if we want to minimize the weight gain with insulin, it's about getting that balance between basal insulin and prandial or mealtime insulin right. And that 0.5 unit per kilogram per day is a definite checkpoint for that. So if you're at that point and the glucose levels, HbA1c are still above target, that's when we need to add our mealtime insulin. And we've got two choices there, sort of discussed very briefly in the introduction. If we're going to have insulin with meals, we can have bolus or rapid acting insulin with that meal, or we have that biphasic insulin, that combination of rapid acting and basal insulin together. And that decision, I'll be honest, is often very much driven by pharma in terms of what they want. It's also going through the options in terms of there's no perfect answer or evidence-based answer to say which is best. But if you do have people that want flexibility, it may be around exercise, it may be around skipping meals or shift work. Typically, that may push you towards more a basal plus or basal bolus regimen. At the same time, those who, not that anyone likes injections, but those that want as few injections as possible, that may push you, for example, more towards biphasic insulin. As I say, there's nothing wrong with switching between the two either, and we'll talk about examples of how to do that too. But it's just realizing that either option is fine, and it's about individualizing diabetes care like it is for all of our whānau with diabetes. In terms of starting, we'll just talk about starting bolus insulin first, and then we'll talk about starting or switching to biphasic insulin. So the easiest way to do this, once again, is to start 4 units of, or 10% of what the total dose of basal insulin is with the largest meal. And that, for most people, that is dinner or the evening meal, but for others, it may vary. For example, many of our elderly people still have their major meal in the middle of the day. So, but that's the time point that you're starting. As I said, it is much of a muchness. Each is good as each other in terms of which insulin you choose. If we're trying to get the dose right for bolus insulin, in the ideal world, what we would have is a monitor glucose levels before that meal and roughly 2 to 3 hours after that meal. And if we're seeing that rise in glucose levels with a meal is more than 3 millimole per liter, then we can increase the dose by 2 units. And it's pretty similar. You get those 3 consecutive checks, all still showing the rise. We keep increasing the dose until that rise of meals is less than 3 millimole per liter, or if an episode of hypoglycemia occurs. So this is basically, it is a way you can set people up to self-titrate their insulin. And I'll show you some plans around that you can provide people to do in their own homes. And then if we are basically the HbA1c still above target, or even better, you might have glucose levels from other meals showing that they're also rising, for example, at breakfast and lunch. It's about adding in insulin as required at those other meals as you go along. Biphasic insulin. Now, most people will have started basal insulin first, and for then you can just switch them over dose for dose to either, you typically choose Rysodeg or Humula Mix 25. For people that have very large carbohydrate amounts at that one large meal, you may choose to go for Humula Mix 50, but often you'll just leave that in the armory if you need to switch insulins. There's actually nothing also wrong with starting biphasic insulin straight away instead of basal insulin. And often now, for people that do have one large meal a day, I'll often start Rysodeg or Humula Mix 25 without starting Lantus or isophane, just because it is often so much easier to get control of their glucose levels with a bit of mealtime insulin in the mix as well. As I said there, if you are, though, starting with basal insulin, it's just dose for dose. I always think it's a good idea when you do that is just to think, you know, roughly, am I going to make sure I'm not going to make them go too low with the meal? For example, if I have switched them over to 30 units of Rhizodeg, I know that's got 10 units of Novorapid or 10 units of rapid-acting insulin on board, and just thinking, is that going to be safe? If so, just crack on. If you were worried about it, there's nothing wrong with starting on a lower dose. For example, you may reduce back to 25 units or 20. There is not necessarily, no prizes for winning the race. It's making sure you just do what's safe and keep making the changes as required. I know that on the pharma sheet or data sheet, it talks about starting 10 units of Rhizodeg. There's nothing wrong with that, but there's also nothing wrong with using our traditional weight-based dosing. If you think about, many of our whānau weigh 150 kilograms, for example. If you start 10 units, it's going to take quite a while to get to target, whereas starting around that 30 units may be more appropriate, particularly once you become more confident with using insulin. If instead of many people just not have one large meal, they may have two large meals. But one thing about biphasic insulin that is different from basal insulin is that the meal that you give biphasic insulin at, people have to eat. Otherwise, if they don't eat, they do have a risk of going low because they do have rapid-acting insulin on board. So it is just about making sure that they do eat at those meals. So it is a bit more rigid. And if you're using twice daily biphasic insulin, I would recommend breakfast and dinner time will be the safest and best time to do that. I know many people will skip breakfast. Once again, Rhizodeg or Huron Mix 25 will probably be your first line insulins that you go to. Now, if you switch again from basal, you literally will switch your basal dose. You just think about, I'll go half the dose in the morning. It could be Rhizodeg or Huron Mix 25. So 15 units in the morning, 15 units at night. Once again, it's about thinking, is that dose going to be safe? And I will say that often people will have, for example, a much larger dinner than they will a breakfast. So there's nothing wrong with, adjusting that starting ratio to 1/3, 2/3, for example. So 10 units of breakfast, 20 units with dinners are outlined there in the slide. It's just about you're adjusting it mainly on what the rapid-acting insulin dose is, not the basal dose. But since there's two types of insulin and biphasic insulin, it does increase the monitoring that you do need. So, for example, if you're giving biphasic insulin at dinner, it's about monitoring the glucose levels before, or at least 2 or 3 hours after dinner, and fasting glucose levels as well. And then for breakfast, you're doing that before breakfast, 2 or 3 hours after, and before dinner. Is giving you the information that you need to make changes. And to be honest, for many people, those changes may only be while they're titrating their insulin. And once again, we're trying to see, do they need to increase? And the way that we know that is if the rise of the meal when they give the biphasic insulin, if the rise in glucose levels is more than 3, and if the delayed glucose is more than 7, we know that that's when we can increase the dose by 2 units. Now, you need both of those things to be present. So what that means is, for example, for dinner, we need both the rise in glucose levels with dinner to be more than 3 and the fasting glucose but the next morning to be more than 7. If it was only, for example, it was only the rise in dinner, which was high, you can imagine if we increase the dose of the Rhizodeg, for example, we've got the potential for overnight hypoglycemia. So it's making sure that both parameters there are present. And once again, we keep going until either the rise in meals is less than 3 or the delayed glucose is less than 7, or obviously if we get hypoglycemia at any time. They're our checkpoints for stopping. And it does, you can see that only one of the two parameters may be met. And the most common situation that we see is that the rise in meals is still greater than 3 millimole per mole. And what we can think about at that stage is, do we think about switching to Humalog Mix 50 as a potential option, just because it's got that greater component of rapid-acting insulin? Do we think about adding in bolus and other meals, for example, if HbA1c is above target? So there's always options in terms of escalating therapy, and very happy to take any questions on that as well. So that's part of what we're, I guess, spoke about switching to Herbal Mix 50. If you find that the rigid routine is difficult with biphasic insulin, or if you find that if you increase it, you've got the potential risk of hypoglycemia other times of the day, sometimes our hand is forced to switch into basal bolus. Now, the easiest way to do this, and once again, all these suggestions to get you roughly in the right ballpark, and you take that total daily dose of insulin and you split roughly half into basal insulin, half bolus insulin. Just so you know, for people without diabetes, that's on a normal diet, roughly about half insulin we produce as basal insulin, half as bolus insulin. That's the sort of rough balance that we try to get. And you can see there, that's part of the reason why we do this when we switch over insulins. I've just got an example here. So if you've got someone that's on 60 units of Humalog Mix 25 across the day, if you split it basically 50-50, you get 30% mantis. And this situation shows a page of 10 units with breakfast, lunch, and dinner to still get that 60 units across the day. Now, for them, once again, I'm going to check that the rapid acting dose is okay. And for some people, it may be that you end up giving 5 units of breakfast and lunch and a slightly higher dose at dinner. That's okay. It's just getting that rough starting point to know where to start from. And talk about like insulin. There are a lot of things that go along with it, and there are ways I thought we'd go through tricks to maximize insulin therapy. And a big part of that is reducing the stigma. Insulin still carries a lot of stigma, and I'll talk about that. Many people will refuse to take insulin, and how can we deal with that situation? Making sure you use the right pens and needles that can make a difference. One thing I'm really passionate about is empowering whānau to make their own changes and to self-titrate their insulin. They will spend well less than 1% of their lives in contact with the practice. It's about how we can set them up, and most people can be set up to safely and effectively titrate their insulin at home. We've introduced the potential risk of hypoglycemia, which we do need to manage well. Ideally prevent from happening in the first place, but there has been some changes or in terms of best management of hypoglycemia. So talk about that. CGM has been absolutely fantastic for our whānau type 1 diabetes and pancreatic diabetes since the funding last year. We need to keep working on funding for type 2 diabetes in this space, but I'll talk about how we can potentially use CGM for type 2 diabetes in this situation, and then just some other tips as well. Now, I will say that stigma that I briefly introduced, there's a lot of rational and irrational stigma there. And I always think it's helpful talking to whānau about what their reasons for not starting insulin is. For example, many would have seen other whānau die within 24 hours or a week of starting insulin. And I think the same is going to happen to them. Or they may be really worried about weight gain, they themselves, or they may have seen a severe episode of hypoglycemia, which obviously a very rational fear to have, and don't want to take insulin because of that. Many people as well, just scared by the pain of injections, which once again, it's a very common, fear amongst all of us. And I think it's really about how we can identify their reasons and talk through those, because many of them can be overcome. For example, around injections, I think people always find it reassuring that they will, I think realistically hurt at least 10 times less than a finger prick, which most of our people with diabetes have done. I think it is helpful to have the first injection with you in the practice. I will sometimes inject myself in terms of show that with just to show that the bark is far worse than the bite. And that can often be enough. And we'll talk about other tips we can get through as well. Part of it is by using the right needles, which I'll come to, but in terms of the pens, it is important to be aware of what comes in a pre-filled option to just need the needles on top versus what needs the cartridges put in the pens, and then what pens color pens are available. I always try to use different colored pens with different types of insulin just to try and reduce that confusion. There's no right or wrong which colors you use. Some people always use like gray or silver for basal insulin, and blue for um, for rapid acting insulin. But to be honest, as long as your people know what insulin's what, that's all that matters. Lantus still comes as a pre-filled option, but it's an all-star pen if you do want to use the cartridges. And we've still got the Nova Pen 4 at the moment for Protophane and Nova Rapid. It's Sabio pens for the Humulin and for Humalog. The Flex pen at the moment from the Nova Mix that's still around is only a pre-filled pen. I think it's really careful. There have been a few errors of people getting confused between Nova Mix 30 and Nova Mix. Oh, so Nova Mix 30 is Nova Rapid. So just trying to get that distinction. Rhizodeg as well. At this stage is not available as a pre-filled pen. It's only available as a cartridge, and that needs to go with the Nova Pen 4. So that will just be aware if you are staying Rhizodeg, that needs to be the case. So unfortunately, at the moment, we will or soon, once Novamix 30 goes, we will not have any biphasic insulin that's pre-filled. So it's just being aware of that, and that may influence your decision on what you use. There's a picture there of the in terms of the Nova Rapid Flex pen, which does have the benefit of being orange and pre-filled, unlike the Novamix 30, which is straight blue. And we've got once again, so all-star pens that go to the Pedra, so all-star for a Pedra and Lantus, and the Huma pen, Sabo to the Humalog and the Humulin N. So hopefully, and the Humalog mixes as well. For needles, you will have to prescribe needles basically for all injections of insulin. We now always typically use the 4 or 5 millimeter needles. That's the green and purple ones that you can see there in the picture. The reason why we use the small needles is it's been shown to get better absorption of insulin, also less painful, less bruising, and less lipohypertrophy as well. So what lipohypertrophy is basically if you just inject in the same spot the whole time, you will get buildup of fatty tissue from the insulin. And what happens then is you then get very unreliable absorption or potentially no absorption of insulin, which are one of the key reasons why glucose levels all of a sudden start going high because insulin's not getting in. So that's why it's really important to talk about rotating injection sites, and why it's a good idea, probably the good opportunities at the diabetes annual review, that you just quickly check your hand, just quickly check injection sites to make sure there's no significant lumps or lipohypertrophy there. If there is, encourage them to rotate. The other thing is if you do have pre-mixed insulins, that's your Humalog mixes, in Novamix 30 or any cloudy insulin, such as Protophane, for example, just tip the pen up and down just to mix before administering. With regards to needles, you can now prescribe 200 on one prescriptions. It only used to be 100. That's now changed, and that allows people to change needles every day, which is great. You do need to think about what your local sharp disposal is as part of that process. So pens and needles, all part of the, I guess, the starting insulin, but are important. So self-titration, as I spoke about, is please feel free if you haven't used any self-titration insulin plans to print them off. I've just put the Arthritis Diabetes Collective website there. Please feel free to use these plans and adapt. But it is about setting people up with safeguards to how they can titrate the insulin in between appointments. I'll be honest, if you only adjust insulin at appointments, you'll really struggle to get people to where they need to be with their glucose targets. And I think it's always great for people to know when to contact the practice should they ever run into trouble or have any questions around that as well. But I would say at least 85% of people can self-titrate their insulin well. If you did have fears, and there will be some people you will have fears, particularly if there's any cognitive impairment, etc., around self-titrating the insulin. There's nothing wrong with still having, a lot more oversight in terms of that. But it's ways we can set people up, whānau up to basically take control, empower them to take control of their diabetes. Around hypoglycemia, so as well as providing a titration plan, I think it's great as well if we can provide written treatment on how to treat a hypo. And that will include when to phone an ambulance and contact the practice. And I've got an example. I show examples of those resources you can provide as well. And I can try and make sure I provide them to Anthony as well, so access through Goodfellow too. With the treatment, so the best treatment is now weight-based, and that's to prevent both under-treatment, so to make sure we get glucose levels up safely, but also prevent over-treatment. There is no, I'll be honest, probably no greater stimulant of appetite than hypoglycemia, and many people might end up having 100, 200 grams of rapid-acting carbohydrate, which typically sends them up straight up the other way. But for most people with type 2 diabetes, it's 30 grams of rapid-acting carbohydrates, of above 70 kilograms. For our whānau with type 1 diabetes, or if they weigh less than 70 kilograms, it's sort of 15 grams of rapid-acting carbohydrate. It's really important to be rapid-acting, and I'll show you just the next slide. We'll go over what options there are. Because if it is complex carbs, such as bread, that'll be a common example, or people love chocolate, mix of fat and protein, you get very slow absorption. You don't get that rapid correction, which is what you need to do to safely treat hypoglycemia. So here's just an example. Here on the right will be for most of our whānau with type 2 diabetes. A lot of people will have sugar in the home or jam, and sometimes that might be easier because the dextrose tablets, for example, and hypofit gels can be quite expensive, and jelly beans are harder to get hold of these days. But it is still quite a bit of rapid-acting glucose, as you can see. This is about the only time we'll advocate for sugar-containing soft drink as well, in terms of that is could also be a quick and easy option if fruit juice or other options aren't available in the house. And basically it's half the amount if they've got type 1 diabetes or weight less than 70 kilograms. And all we're doing is we're making sure we treat hypos, we recheck glucose levels again in 15 minutes. If you check before that, often the glucose levels won't have come back up. So it is roughly about that 15-minute time point. If glucose levels are still low, we're repeating treatment. If glucose levels have come up, that is a good time to have the next meal or just a small carbohydrate snack. This is the time you may have complex carbs such as toast or crackers, etc. I think it's a good idea if they do check their glucose levels still within the next hour or so to make sure that glucose levels are staying up. Just because hypoglycemia, I'll be honest, the biggest risk for repeat hypoglycemia is one episode of hypoglycemia, and that is just because you've used up your body stores, and that's why it's important just to make sure people stay safe. It's also reminding people that, hypoglycemia can be life-threatening. So if it is anyone that's unresponsive, it is about phoning an ambulance. If you do have able, and it's be stressing that's maybe in the practice where you can safely, you got no concerns over the airway that you can give sort of glucose through the cheek, and the gels are absolutely fantastic for that. Because if you've got severe hypoglycemia, treatment's always glucose. If you got it, if you don't have glucose available, or you're not sure about airway safety, that is when you can give glucagon IM as intramuscularly as well. I think if there ever is someone does have a severe episode of hypoglycemia, it's always great to find a cause for that. When alter the regimen is required, I will say when we increase insulin, generally increasing doses by 10% is safe and effective. If you're forced to decrease insulin because of hypoglycemia, I'll be cutting back by at least 20%, just to give you a guide of sort of degree you often need to cut back on. The other thing is that when people say that they've taken too much insulin by by accident, which is a common report. Just beware that studies have shown about 80% of those accidental overdoses aren't accidental, and it's a call for help, just because of the much greater risk of depression and diabetes, the stress associated with insulin therapy and diabetes. So it may just be a case you do just delve a little bit deeper into that to make sure that sort of mood, mental health wise, everything's okay, because often it's just not an accident. It's just a flag back to your attention as well. There are very good resources on Healthify. Also, there's hypoglycemia resources in terms of algorithm and how to get that glucose on board on the Aotearoa Diabetes Collective website as well, if you're they're there to print off and use freely. So continuous glucose monitoring is another important adjunct. It is the gold standard of glucose monitoring. It overcomes so many of the barriers that we get from finger pricks, but we do have the issue at the moment in Aotearoa that's only funded for type 1 diabetes and pancreatic diabetes, other rare forms of monogenic diabetes. It's the same in Australia. It's the same in most countries in the world. But it is about just highlighting that people with type 2 diabetes, particularly those on insulin, still greatly benefit from continuous glucose monitoring. Now, at the moment, everyone with diabetes is entitled to have a trial of one free Freestyle Libre sensor and one free Dexcom ONE Plus sensor. What that means is all of a sudden you've got 25 days, which you can use for titration of insulin, and this is often the perfect time to use that. I know of some practices and PHOs are also funding select CGM use for titration of insulin, and that might one thing to explore if it's available locally. And there are also we have many whānau that choose to self-fund their CGM on the disability allowance if they're eligible. And we have our local agreement with MSD, and also it does vary a lot from region by region. It doesn't necessarily align with the health or the old health districts either. But particularly for those on insulin at high risk of hypoglycemia, and that occurs all on dialysis, or if they're young adults or pregnant or got any sort of physical cognitive impairment, they can't do finger pricks, but they will. Some will choose to use the disability allowance. Now, because the sensors are expensive, and I think it's I'll put the prices down there and sort of broke it down. This is the current price per day. Down the bottom, we've got what percent that takes up of the disability allowance, and for many people, this is just far too much because the disability allowance is not much. It's only about $80 a week maximum that has to go on other things and can't fit in a sensor. The cheapest sensor that was available was the Lynx CGM. Now we've now got the CareSense Air sensor soon to be available, which is about half the price of to be about half the price of Lynx. So that will come in just over $3 per day. So that will provide another option, I'll be honest, what we need with that competition in the market to drive prices down to enable our whānau with diabetes to use sensors, particularly at acidic times, and around insulin titration is a really key time for that. And happy to take any questions on that. We've also developed basically a template letter that you can use just to literally put your patient's name on and to fill out the forms for the disability allowance that they can take to WINS, just to help with that process. Once again, it's free to use. It's just to really to save time and try and reduce our inertia at making this happen. But many people find that useful. When looking at CGM reports, now I think many of us are becoming a lot more comfortable with looking at, what are we actually looking at when we look at CGM. Now, I just thought I'd just go over that quickly again. So, our time and range are at, it's a green pip here on the graph. That's the percent of time between glucose levels between 3.9 to 10 millimole per litre. Now, for most people, we're aiming for a target greater than 70%. And ideally with 0% below range or in the range of hypoglycemia. The other thing we can look at quickly on the front screen is the GMI, or the glucose management indicator, which is basically the estimated HbA1c. And many of it, and we know how to interpret that. But that will be the main sort of targets on the first page. On the second page, and I'll be honest, even though you might find that you get an 18 to 20 page report, I don't think you need to, for 99% of the time, go past the first 2 pages. You can look at it quickly and get all the information that you need. So the ambulatory glucose profile just shows you what your glucose levels are like over a 20, or the average glucose levels are like over a 24-hour period. It starts at midnight and it goes through that whole 24 hours to midnight the next day. In there, you've got the time in target range. You've got the dark line, that is your median glucose level. You've then got the shading right to the 25th and 75th percentiles, and the 95th and 5th percentiles, and just in a very quick time, you can see what the sort of the average glucose profiles across the day. And underneath, you've got the daily glucose. You got the individual glucose profiles for every day. For someone like this, and this will be a typical trace. The reason why I chose this one, it'll be a typical trace for many of our people on with type 2 diabetes on insulin, and that you could argue that they're on slightly too much basal insulin at night, which is why they're potentially going low, and they're not on enough mealtime insulin during the day. So just got that progressive hyperglycemia across the day, and that's where we'd tailor that insulin to meet the glucose profile. So in terms of just going quickly over other tips, so spoke about insulin-induced weight gain. And the ways that we can minimize it is a real entity. Is one, healthy eating, I'll be honest, is important at all times of the diabetes journey, but particularly also when starting insulin. Movement in terms of that reduction in glucose levels makes a big difference as well. It is the perfect time for dietitian input, and for many centers across, or many regions across the motu, as soon as you start insulin therapy is a time when you can access community dietitians. I really encourage that to help. It's not only just reducing weight gain, but matching insulin doses or matching their food to their insulin doses as well. Introducing mealtime insulin early and just not increasing the basements will definitely help limit weight gain. Insulin itself has got no calories, and that's the other way to look at it. And so it's about how can we reduce everything, the weight gain on top of that. If you ever have someone that is needing to eat to prevent hypoglycemia when on insulin, you've got them on too much insulin. So that's when we need to cut back. If you've got them in the right dose of basal insulin, people shouldn't need to eat during the day. And that's it's a rough guide to whether you got on the right dose. If you find that people if they skip a meal, they go low, you got them on too much basal insulin, and that's when we need to cut back. It's also really important if we maximize our non-insulin glucose lowering therapies, we can ideally get on the lowest dose of insulin possible, so we've got the lowest chances of weight gain or hypoglycemia. And you will have many people still in your practice if you who have the possibility of getting off insulin with using the new insulin glucose lowering therapies. So, for example, for those that on roughly, if they're close to HbA1c target and they're less than 30 to 40 units on less than 30 to 40 units a day, there is a chance, for example, if you introduce a GLP-1 receptor agonist, you can get them off their insulin. It's probably slightly less than that, the Goodfellows or Jardiance. But just thinking about, I could actually potentially get some of my people off insulin. On the same token, if you're someone that's had diabetes or type 2 diabetes for a long time and they've got beta cell burnout, and just unfortunately we won't get them off insulin. They will still need insulin to stay well and healthy. So it's about appreciating that, and that some be able to come off, but some won't, and setting those expectations. Around depression and diabetes distress, I've spoken about that as being a big barrier, and I think screening is always important, and then utilizing supports as appropriate and when available. And there are tools. I know many PHOs have embedded the PHQ2 and the DDS2 into their diabetes and review, for example, just as quick screening tools to work out whether they need to delve in further. It's also remembering that if we do have people, particularly that on large doses of basal insulin, when they get sick or they may be fasting for a procedure, that's a time we need to do cut back the dose. So I know often a knee-jerk reaction when someone's not eating is they need to stop all insulin altogether. And for most people, they end up in a worse off space than beforehand. So a rough rule of thumb for people that sort of sick day management on insulin that aren't eating or got very minimal oral intake is to stop their mealtime insulin and sulfonylureas as well, if they're on that, and to stay on their basal insulin, but to reduce the dose by about 20 to 30%. If they're on very large doses, you may end up even needing to halve the dose just on the days when they're not eating. If they're doing a lot of exercise, and also it's be strenuous exercise, for more than 45, 60 minutes, that's another time you might find that you need to cut back on the insulin. Just showing the PHQ-2 here. It's just those two quick questions there. Over the past 2 weeks, have you had a little interest or pleasure in doing things or feeling down, depressed or hopeless with that scoring system? If you score 3 or more, that's when you go and do the full PHQ-9, which then help guide you to best treatment. I will say that clinical assessment always out trumps the questionnaire score, but it's just as a helpful tip. And the DDS2, once again, it's 2 questions, just asking, over the past few weeks, in terms of these situations, and 3 or more is suggestive of significant diabetes distress. And this is one time I would access, what supports you do have available. That may be psychology in primary care. You may have health coaches, chiropractor, your nurse and pharmacist staff to spend more time with people just to help try and reduce that distress. So just quickly to finish with other tips. I haven't said, I don't think I've highlighted before, but it's just ideally making sure that we administer bolus insulin and biphasic insulin before meals. The caveat there is that it's about meals that know they're going to eat. So if they're going to be interrupted by work, kids, or whatever, it's still fine to inject when eating, or potentially immediately afterwards, but ideally beforehand. It will take at least 45 minutes before you start seeing any decent effect of the insulin. I think a regular routine is helpful, because we'll still have many people say, I forget to take my insulin. So I say, there's actually no reason why you can't take your basal insulin at night, or your Lantus, or isoplane at night with dinner. And so I'll say, keep the pen on the table, give it to just before you have dinner, and that can be a useful trigger. But it's just about doing whatever works and being pragmatic. Spoken about cutting back on hypoglycemia. For cognitive impairment, it can be a really tricky situation with insulin, and how we can go help with that. And often that may be family members. There are some useful adjuncts that you can get as well. So Nova Pen Echo only goes with the Novo products, unfortunately, but it will tell you how long since your last injection. So will the InsulCheck device, which can go on any pen. You can get it from Diabetes New Zealand and other sources. That will tell you how long ago since you've injected as well, which can be helpful for people to know have they given themselves the insulin or not. Pain is another significant, spoke about can be a significant barrier. There are tricks of the trade to help. One may just be simple distraction. Ice to the area can help reduce pain as well. There are devices as well that work by the gate control therapy, such as Tickle Fix and Brave Buddy. I'll show them now. Basically, by stimulating the skin around it, you reduce the pain from the injection itself. It just goes on the end of the pen and really available. And here's an example of the InsulCheck device that will tell you the time since injections as well. It can go on the pen and can be helpful. If you haven't seen our national insulin algorithm, encourage you to check it out. That's the website there. Everything I've spoken about tonight pretty much is on there, and it can be a really handy resource. I know some practices have printed it off and chucked it on the wall, but it's just there available. We'll go through how do we start basal insulin, how do we titrate basal insulin, do we add in bolus insulin or biphasic insulin, how do we titrate that? In terms of, do we do once a day, multiple times a day? How do we add in bolus insulin, other meals? What are the other tips around prescribing and what to do if HbA1c remains above target and in sick days as well? So really useful resource, which I encourage you to check out. So just in summary, insulin, even though we've got all these other tools in the armory, is still a really important glucose-lowering therapy in type 2 diabetes. There's a lot of clinical inertia around insulin. It's how we can improve that for our whānau with diabetes. There are major changes in the availability of insulin to be aware of, and hopefully you're much more happy with that tonight. In terms of and just guidance about how to get in that right ballpark and titrate insulin safely, quickly, and effectively. And yeah, it's one thing I will say would come confident with. Happy to take any questions on how to help. It's how we can minimize the adverse effects of weight gain and hypoglycemia and that stigma of insulin therapy, including amongst healthcare professionals. Is still a major issue, and it's how we can help improve that. I might hand it over to you now, Anthony. Happy to take any questions.
We have a lot of questions, so we should get straight into it, and hopefully we can get through as much as possible. Um, One of the questions was around blood testing and specifically C-peptides.
Yep.
In Wellington region, it's not available without specialists sign-off or funding. In terms of availability around primary care, yeah, what are your thoughts on that? Yeah.
Yeah, it does vary a lot from region to region in terms of access. It's something we're trying to work on at a national level in terms of standardizing that and being available for primary care. I will say just quickly, I think we under order C-peptide and over order at the same time. And what I mean by that is really you should only order a C-peptide when it's clinically relevant. Most of our people with type 2 diabetes will have classical type 2 diabetes who do not need their C-peptide measured. It's when we're worried particularly about the other types of type diabetes, being type 1 diabetes, pancreatic or monogenic diabetes. I always say, always please do a C-peptide that's stimulated or after a meal. So making sure that glucose is above 8. There's also no point in doing a C-peptide really if someone's been admitted with either DKA or diabetic ketoacidosis or hyperosmotic hypoglycemic syndrome, HHS, because you will get an acute phase of suppression of endogenous insulin production where you get a falsely low C-peptide. So it's about, in an ideal world, we'd all be able to we'll be able to order antibody or anti-GAD, anti-IO2, and anti-zinc-T8 autoantibodies and a C-peptide with a paired glucose when clinically appropriate, rather than being gatekept, but making sure that we're not testing it appropriately. But there'll be a lot more guidance on that coming up soon.
There was a few questions around initiating insulin with high HbA1c. There's a few case examples of patients with HbA1c of 97,
Yep.
otherwise fit and well. Their previous HbA1c a year ago was 47, and then also around examples where patients have rapidly improved their HbA1c without insulin.
Yeah, there will be, and that was, I guess, to try to emphasize at the time, it's just to consider insulin at that point. It's definitely not an absolute rule, because you will have some people who will be able to get to target without insulin. There's no doubt about that. With the rapid, on that, with the rapidly increasing HbA1c, just that is just one little red flag to think this may not be type 2 diabetes, just because it is generally a lot more of an insidious onset. If we think about then lowering it, just quickly, metformin will reduce HbA1c at most by about 15 millimole per mole, vildagliptin by about 5 to 10, empagliflozin probably about 10 to 15, sulfonylurea is about 15, pioglitazone about 15. But these are all additive. But all this, so if you can, even if you put everyone on potentially an HbA1c above 90 to 100, you may still not get them down to less than 53, particularly if there's not much room to change diet-wise. And they are the ones where there's not much room to shift, that I would be thinking about insulin, or if there are other red flags. This may not be type 2 diabetes, but there will be many who will have a big capability to make changes, and the other ones where obviously it's very reasonable to hold off and see what happens if they've got no symptoms of insulin deficiency. And I think that's a key part. Are they clinically insulin deficient? And that will give you a guide. It's hard to give a blanket answer to, but happy to answer any specific questions if there are any.
Regarding beta cells, there's a few questions about preserving beta cell function, earlier treatment, for example, in pre-diabetics, and using oral medication in that context, but
Yeah.
also whether they regenerate in the future.
Yeah, so it seems to be that you get like a slippery slope endpoint where there is no reversal, but it is important to go early. Now, at the moment for pre-diabetes, the only real evidence is around metformin in terms of preserving beta cell function. There is some role once you have diabetes for vildagliptin and metformin in combination. But to be honest, any glucose-lowering therapies, if you can reduce that glucotoxicity, those high glucose levels, you will preserve beta cell function. Weight loss, for those that are overweight, is the other big thing, which should be great to try and encourage. And it's difficult. Probably the most successful intervention out of most things in terms of achieving remission is a very low energy diet, such as a direct style intervention, which many of you will be familiar with. And I'll be honest, we desperately need a national a program for that to enable people to have a much greater chance of remission of their diabetes. Once you've had diabetes or type 2 diabetes, sorry, for 6 years or longer, that's when your chances of remission really start dropping off. So if you can go hard, go early, that would be a really key message.
One of the questions here is a couple of patients have been on Jardiance and insulin,
Yep.
and then they've switched to Trulicity and insulin, and then blood sugar control changes were worsening. And do we need to increase the insulin in that context?
Yeah, I think always be driven by your glucose levels in terms of whatever you do with therapies and diabetes. Would be a good rough rule of thumb. An ideal world would be like every other country. We had access to both empagliflozin and a GLP-1 together, rather than being forced to choose one. If you can get on funded empagliflozin under the heart failure criteria, please do it, because it means we can get that under the heart failure criteria and the GLP-1 under diabetes criteria to allow funding of both. There are times where we will have many funder that will self-fund empagliflozin on the disability allowance, or even without the disability allowance. If you use half the 25 milligram dose a day, it works out to about $42 a month, which does become financially able for some. It's still a lot of money. This is about how we can increase the options. Because I'll be honest, I always try for type 2 diabetes to try and maximize the non-insulin glucose lowering therapies, even though insulin still has an important role.
There's a few questions around maximum doses of insulin, I guess, with that risk of weight gain.
Yeah.
And if patients are already on a higher than 0.5 units per kg per day,
Yeah.
what do we do?
It is just a checkpoint, so it's not an absolute rule. But for example, if I had someone that, I'll just use it out of ease, like 100 kilograms, and they're on 100 units of Lantus a day, and their HbA1c was still above target, I would actually personally just reduce that down to 50 units. So down to that 0.5 units per kilogram, and introduce prandial insulin early. You will have, I guarantee you will have some, on very large doses who may, miss it one day and notice no difference, for example. And it's just about how can we get that balance right. And I could talk a lot about that, but it's about, I think if you do have someone that is on very large doses that you're thinking about are they roughly on about 50% basal, 50% bolus insulin like a normal pancreas? Now, you will have people on low carb diets who need a lot less sort of bolus insulin as part of that ratio. You will have others who eat a whole lot of carbs who you do want them on a much greater sort of ratio of meal time to basal insulin. But there's nothing wrong with thinking, actually, I'm going to cut their basal insulin back and I'm going to introduce some mealtime insulin. You find that we actually reduce both the risk of high and low glucose levels and weight gain.
With initiating insulin, there was a few questions around oral medication and adjusting that. Yeah, any advice for
So
that?
basically, rough rule of thumb is continue everything, all your other non-insulin glucose lowering therapies. The only one that you need to stop really is sulfonylureas when you're introducing a mealtime insulin. And you could argue it's only once that you got on decent doses of mealtime insulin at that meal. Now, what that means is, for example, if you had someone on that was just on Rhizodeg with dinner, and on twice daily glipizide or glucoside, you'd stop the dinner dose when you introduce the Rhizodeg, but you may still keep the breakfast dose of the glipizide or glucoside going. And you keep all their other medications going. So you keep the metformin going, the empicoflows and the GLP-1, the pioglitazone, okay, whatever else they're on. You keep going. It's another really, I guess, useful time to reinforce healthy eating as well. It's everything, I'll be honest with, we've talked here a lot in diabetes about switching between therapies. Often all you do is switching is chase your tail. Pretty much everything in diabetes, it's add-on therapy, unless you got side effects, or if you're adding in mealtime insulin or soft areas. It's about the only time you take something out.
There's a few questions regarding Lantus. So one person's been advised that a former colleague advised patients to adjust their NOC dose based on post-dinner BSL, and then also looking at rationale for twice daily Lantus as well in terms of dosing.
So if you're adjusting it, if you're taking nighttime Lantus and it won't actually get any action realistically to kick in for at least 3 to 4 hours and won't reach its peak activity to sort of overnight and morning. You will potentially run yourself into trouble with if you're just titrating on post dinner levels. So I would be advocating for the next morning, if it is nighttime dosing. With twice day Lantus, I will say anecdotally that the biological activity of Lantus isn't as long as what it says on the printouts. And for people with type 1 diabetes, we did use twice day Lantus quite often, and perhaps even up to a third or half of people at most. Most people with type 2 diabetes, though, I will say, will get away with just once daily Lantus. It does get a little bit tricky when you're on really large doses of insulin, and I would say, particularly once you get on doses above 40 to 50 units a day, you start to see a bit of a drop off in reliable absorption. So sometimes it's easier to give 2 smaller injections than as 1 large injection, or sometimes you actually go above the maximum of the pen, which is not uncommon as well. In that situation, you're probably better, if the person's happy, giving that Lantus or whatever basal insulin is twice a day rather than 2 injections at once. But for most people with type 2 diabetes, I think once a day is typically enough.
And with eating and education around carbohydrate monitoring while starting on insulin on bolus, is this required for like fast acting insulin as well?
Yeah. It's a great time to get a dietitian involved if you can. And many PHOs now have access to a dietitian. I know many don't, and many don't have any access to community dietitians. It is a time to be aware of, I guess, of carbohydrate containing foods. As if someone is on rapid insulin, it's great to have carbohydrate containing food at that meal. It doesn't have to be strict carbohydrate counting. It's a lot different from type 1 diabetes. So I think it's important to be aware of that. But if you do have someone that, and this is where it does become easier with bolus insulin, for example, they may skip a meal, and they may just have salad, for example, and then they can just skip their bolus insulin at that meal. But if they are on, having a rigid routine, they are going to have some carbohydrate at that meal. I would probably say most New Zealanders are on have their daily requirements of carbohydrate at 1 or 2 meals across the whole day, rather than how much they eat. So it's about trying to get that carbohydrate awareness. It is often better to spread that carbohydrate across the day, but saying that if you do have someone that is potentially going low at times of the day, when they're not eating, you've got on too much basal insulin and to cut back.
Regarding some of the special authority criteria for diabetes medication,
Yep.
depends on HbA1c target. In terms of getting that funding
Yep.
and deferring, I guess, treatment, for example, insulin to get that funding, I guess your thoughts around that.
Well, as a caveat, I would say only do what you're comfortable with in terms of around abiding a special authority. But the wording is quite, I can't remember the exact wording off the top of my head. It does discuss about clinical appropriateness of other medications. And sometimes it's not necessarily clinically appropriate in terms of insulin with starting. There are also times where, and the HbA1c criteria is based on lowering of glucose levels and not around cardiovascular and renal benefit. So I'll be honest, I will try and go back in the notes and try and find any evidence I can for meeting the criteria to get them onto treatment. It is an unfortunate hoop that we have to jump through, in terms of having to try all the other glucose lowering, particularly for GLP-1. We know that the benefit. At the same time, we do, even though we've got a fairly good supply of GLP-1s at the moment, it can vary a bit around restriction from pharmacy to pharmacy. So it would be great if we did make sure we used our, make sure that those at highest at risk got access to our GLP-1 receptor agonist therapy versus others where other glucose lowering therapies may be more appropriate. And just to be clear, those with, ideally everyone with renal disease and or cardiovascular disease and type 2 diabetes in Aotearoa would ideally be on an empagliflozin and or a GLP-1. And that would be really keen for that group to have access to care. Whereas if you did have someone, for example, particularly the elderly that had no evidence of complications, for them you may actually be thinking about metformin and vildagliptin, for example, rather than just jumping straight into the newer therapies.
Regarding HbA1c interpretation with, for example, thalassemia or other hematological disorders, how do we interpret that diagnosed directly?
I mean, HbA1c, as they point out, is only as good as the hemoglobin or HB. So if you've got an altered red cell span for whatever reason, your HbA1c will potentially be, usually it's falsely low. In that situation, what I would do, you got a couple of options. One, your glucose levels. Glucose levels always give you the best guide to see where you think you're in the right ballpark with the HbA1c. It may be a time where you say, look, do I use a trial of a sensor to check that your glucose levels are compatible? The other way that you can do it is if you've got completely unreliable HbA1c, you can order a fructosamine, which is essentially glycated albumin, which is what we used to do before HbA1c. It's a little bit trickier to done in Northland, but we still occasionally order those for when HbA1c is completely unreliable. But if you're ever in that situation, I'll be honest, pregnancy is probably the most common situation where HbA1c becomes unreliable, as glucose levels will always be your best guide.
Yes, thank you for that, Ryan. And we appreciate your time and also expertise shared with us this evening as well. Thank you everyone for joining us tonight. Have a good night and ka kite.